Hi, I'm Dr. Charles Eaton. I'm a hand surgeon, and I'm the founder and executive director of the Dupuytren Research Group. This is a slightly modified version of a public presentation that I gave in Boston on November 13th of this year. I'm going to talk about these topics. What is Dupuytren? Who gets it? How does it progress? What seems to make it better or worse? How do doctors currently treat it? And what do we have to do to find a cure? First things first, Dupuytren Research Group is a 501c3 nonprofit public charity. We're patient-centered and patient-governed, and our mission is to remove obstacles to developing a Dupuytren cure. We're independent, we have no commercial ties, and I have no financial conflicts of interest. The Dupuytren was a very famous surgeon in the early 1800s. He famously treated Napoleon's hemorrhoids, but that's another talk. Dupuytren disease bears his name, and Dupuytren disease is the underlying condition that can show up in a number of ways. One of the ways that it can show up is in producing Dupuytren contracture. Not everyone with Dupuytren disease develops Dupuytren contracture. Dupuytren is treated by surgeons, but it's actually not a surgical disease, it's a medical disease for all of these reasons. It's multifocal. It doesn't just affect the palms, it can affect the back of the finger joints or the toe joints, where it's called knuckle pads or Garrod pads. It can affect the soles of the feet, where it's called Lederhose disease. And these three conditions all seem to be just local manifestations of the same underlying condition of Dupuytren disease. There are two other conditions which seem to be related, but the exact relationship is not quite as clear. One is frozen shoulder, which is a painful shoulder problem that can result in shoulder stiffness. It's not the same as a rotator cuff problem, and it's more common in women. The other sort of related condition is Peyronie disease, which affects the penis, clearly more common in men. Dupuytren is a systemic problem, not a local problem. People with severe Dupuytren disease are more likely to have a number of other benign medical conditions as well as malignancies, both cancer and sarcoma. People with severe Dupuytren disease don't live as long on average as people without Dupuytren disease. Dupuytren is genetic. It runs in families. It's age-related. It's more common the older people are. It's biologic. The battlefield is microscopic, and the cells that are involved are myofibroblasts and immune cells, and also changes in the extracellular matrix, which is the mortar that holds all of our cells together. Dupuytren is a chronic condition. It's a process, not an event. And all of these together add up to be consistent with Dupuytren being a medical disease, not a surgical condition. Dupuytren usually affects the palms. It doesn't always. I've seen people that had every other checkbox checked with Dupuytren-related conditions, but no direct involvement of the palm. The first signs of Dupuytren are a lump in the palm called Dupuytren nodule. And Dupuytren nodules are collections of some of the special cells that are involved with Dupuytren biology. Dupuytren nodules aren't a structural change in the hand. They are just an accumulation of these cells, and if it were possible to make all those cells go away, the hand would resume its prior normal appearance. If Dupuytren nodules progress, and they don't always, but if they do, then the next stage is a cord. Now, a Dupuytren cord is a collection of the protein that we are made of, called collagen, that aligns itself along the length of the finger. And Dupuytren cords, typically you can't see unless you're really trying to straighten your finger out. When the hand is at rest, you can't see them. If cords progress, and they don't always, but if they do, then the next event is a Dupuytren contracture, which is that the cord is short enough that it prevents the finger from being straightened out all the way. So cords and contractures are permanent mechanical changes in the hand, and typically they need mechanical treatments to undo them. Now this picture shows these little X's on these lumpy areas in the person's palm on the left, and those are not Dupuytren nodules. I point them out so that there's no confusion. These are called the palmar monticuli, or little mountains of the palm. And what they are is normal fat pads that are normally in between the fingers that cushion the nerves and arteries that run out from the palm out into the fingers. And these can be seen in some people just normally, but when people have Dupuytren, the tissue tightens in front of the finger on each side, and it tends to make these areas pooch out. And so they stand out, but they are soft and they're not nodules, and we'll circle back to this in a little bit. Dupuytren can affect the palms and the backs of the knuckles and the sole of the feet, but it only contracts in the palm. Knuckle pads don't contract, and letter hose disease almost never contracts to pull the toes down. And these differences of the same biology behaving differently in different locations is a clue to Dupuytren biology. Let's talk about the anatomy of the palm, because it'll help demonstrate why events happen the way they do with Dupuytren disease. The skin of the palm is different than other parts of the body. You can't slide this skin around. It's really fixed down to the hand. You can't get a pinch of it while you're trying to straighten your fingers out. This is different than other parts of the body. In the back of the hand, you can pinch the skin, you can slide that skin around. And the reason for that is the anatomy is very different. In some ways, the skin of the palm and the tissues under the skin are put together like a quilt. When you want to make a quilt, you lay down a layer of fabric, and you lay down a layer of padding or batting, and then another layer of fabric, and then you put stitches in between these layers, crossing all of the layers, and that holds the top and the bottom down to each other, but it also keeps the top and bottom from sliding relative to each other. And you can put in more stitches and tighter stitches to influence what the surface looks like, whether there are creases or whether there aren't creases, and the geometry of those creases. Now in the palm, the creases in the palm aren't just like folds in a wrinkled piece of cloth. They're areas where, like a quilt, the skin is anchored down to underlying structures with more threads and tighter threads. If you were able to peel the skin off the palm, you'd see these different structures underneath the skin. These are layers that are kind of like canvas cloth. The most superficial layer, that's marked here in green, is the superficial palmar fascia. And that's often involved with Dupuytren. That's not the source of Dupuytren, because people can develop Dupuytren changes in areas that there is no palmar fascia. Underneath the palmar fascia are other layers of this cloth-like tissue that are connected together. Now you can see that little square in the middle of the palm diagram. If we were able to take that square and roll it around, we would see that there are connections. So there's skin on the surface, and then the little gray blocks are actually the threads that hold the skin down to the underlying palmar fascia at this level. And then under that, there are other layers of tissue that are connected together all the way down to the bone. So this anatomy actually anchors the skin of the palm all the way down to the bones in the back of the hand. And when you grab and pull onto things, if you hold something firmly and resist its motion in your hand, that force is absorbed by the skin. And if you grab hard and it causes some inflammation in that area, in people with Dupuytren, that can trigger the biology. And so that biology tends to be activated just under the skin. And when it is, if you have Dupuytren, then the body's response is to act kind of like a scar tissue, which is to build up collagen and to make the area shrink. So that's typically what's happening mechanically with Dupuytren disease. So who gets Dupuytren? I've gotten all of these pictures online. These are publicly available pictures, and I wanted to track down pictures of people that showed the face and the hand in the same picture. And these are celebridupes. These are people that you might recognize or know the names of. So we'll start here in the upper left corner with Samuel Beckett, who is a playwright who wrote Waiting for Godot. And his ring finger is pretty bent from Dupuytren disease. Next to him is Frank Sinatra, who has Dupuytren in the exposed palm there. And rumor has it that he stopped performing either from his Dupuytren or from complications of its treatment. Next to Sinatra is Joe Bonsall. He's a singer and banjo picker with the Oak Ridge Boys, and you can see here he's holding that jar with his index and middle finger, because when this picture was taken, he couldn't straighten out his ring and pinky finger enough to get around the jar. He's had surgery since then, and he's better. Next to him is actor Chris Pratt, who has geographic changes in his palm which look very much like early Dupuytren disease. I don't know if he has it, but that wouldn't be surprising at all. He's using this move to try to push away a dinosaur. It seemed to be pretty effective in the movies. Next to Pratt is comedian Bill Murray, who has contractures in both of his hands. Below Bill Murray is Vladimir Putin, who has kind of subtle findings. If you look at his ring finger, it's bent a little bit more than his adjacent middle and pinky fingers, and he's got exaggerated palmar monticuli at the base of his ring finger on each side. So very likely he has Dupuytren. Next to Putin is Reagan, who had surgery for his Dupuytren when he was in office. Above Reagan is actor Bill Nighy, who has pretty severe Dupuytren, and it looks as though his fingers are all the way in his palm. His fingers are actually only about like this, but he has learned to hold them down so they don't catch on things. And that's a common thing that people who have very severe contractures will learn to do. Next to Reagan is Mitt Romney, years ago on the campaign trail with early changes of Dupuytren. Above Romney is comedian Chelsea Handler, who had early Dupuytren when she had Dr. Oz on her show, who confirmed her Dupuytren. And the bottom left is Max Planck, a very famous physicist of the Max Planck Institute now, holding his hand against a window with a cord going up to his ring finger. Above Planck is Sam Neill, who was an actor who was with Chris Pratt in some of the Jurassic Park movies, and he clearly has a cord going up to his middle finger. And on the far left is Sam Elliott, an actor who has had surgery for his Dupuytren. So what do all these people have in common? One is that they're all pretty clearly of European descent. They're all Caucasian. The other is none of them have typically Scandinavian names. And I mention this because there's this rumor that Dupuytren is a Viking disease, or some people say it's a Celtic disease, but there's no evidence to back this up. This actually started with an idle speculation in a textbook that people took, and it made good copy and people ran with it. But here's why it's not true. In 2015, Leslie published a study in the journal Nature, and it was a genetic archaeologic study of following the trail of people who migrated to the British Isles from other areas of Europe. And you can see the people from what's now Norway settled into the light brown or gold areas on the British Isles. The people from what's now Denmark settled into the blue areas. Those dots of blue in the blue areas are areas that have a high concentration of Scandinavian names. And so that's where we should find a lot of Dupuytren. But in 2019, published a study of the prevalence of Dupuytren in the British Isles, and you can see there's no relationship between the two. Dupuytren is not clearly a Viking disease, and the Vikings actually were not genetically homogeneous. They employed mercenaries, and so it sounds great, but don't blame Vikings if you have Dupuytren, and don't claim Vikings if you have Dupuytren either. The other thing that came out of Leslie's paper was that the Celts were not a genetically monolithic group. They were, the Celtic name refers to a culture, not to genetic ancestry. So sorry to break that to you. Ancestry is very important in Dupuytren. The big group that's at most risk is people of European descent, and in the United States, European Americans have the highest prevalence of Dupuytren, and compared to European Americans, Hispanic Americans have about 1/3 the prevalence. African Americans about 1/5 the prevalence, which is interesting because the average African American has about 1/5 European ancestry. And Asian Americans in one study had about 1/10 the prevalence. And this isn't a surprise because ancestry is a big factor in other fibrotic diseases. So diseases that cause abnormal scarring or scar-like tissue, like Dupuytren, are called fibrotic diseases, and some are more common in people of non-European descent, like keloid, scleroderma. Some are more common in people of European descent, like pulmonary fibrosis, and right there, Dupuytren, Peyronie, Lederhose, frozen shoulder. And some of them don't have a clear ancestry influence. They may be more related to environmental factors or viruses, things like that. Gender and age also affect the prevalence, the percentage of people that have Dupuytren. So men tend to get Dupuytren at an earlier age than women. Women catch up after the 60s. Women tend to the prevalence of Dupuytren increases about the same rate as in women as men, but men get a head start. So in the 50s, about 1 in 10 men of European descent will have some changes in their palms consistent with Dupuytren disease. That number goes up to 1 in 4 of European descent men in their 70s. It's not until women get into their 70s that about 1 in 10 will have evidence of Dupuytren. But you can see it's surprisingly common. Clearly, not all of these people progress to developing contractures, and most people with Dupuytren have mild or early changes. Now, the ratio of men to women changes based on age. So if you look at people in their 40s, it's about 30 times more common in men than women. In the 50s, it's about 10 times more common. In the 60s, 4 times as common. In the 70s, it's twice as common in men as in women. And then when you get to the 80s, it flips. And past a certain point, it's actually there are more women with Dupuytren than there are men with Dupuytren. And one of the explanations of that is that men don't live as long as women, both genetically, and they tend to make worse life choices. So we'll pause here and ask what might seem like a strange question, which is, what is Dupuytren for? Why do people have Dupuytren? And from an evolutionary perspective, people that have genes that make them less healthy, that impact their health in a bad way, those genes tend to get bred out of the group. And Dupuytren is a problem. It interferes with people's lives. And so why do these genes still exist? Well, one way to look at it is that people can have genes that give them illnesses, and those genes may also give them some kind of protection against other conditions. So the classic example of this is sickle cell anemia. Sickle cell anemia is pretty common in Africa. The other thing that's pretty common in Africa is malaria. So people that have sickle cell, they can be very sick. It's sometimes called sick as hell anemia. People with the bad version, they don't live as long, they don't have as many kids, and so you'd think that would get bred out of the population. But sickle cell trait, where people have one of the genes but not both of them, gives people resistance to dying from malaria. So it stays in the gene pool. So having sickle cell genes in the gene pool is the cost of doing business with malaria for that population. There's an interesting study that just came out in Nature magazine about a month ago that had a similar conclusion for the genes that cause inflammatory bowel disease. And this was another genetic archaeology study that looked at genes in people before, during, and after the Black Death, which killed about 60% of Europe's population in the early 1300s. And what they found was that people who survived the Black Death were more likely to have a set of genes that involved the immune system. And so those were enriched in the survivors. It was not, it was a pre-existing gene pool, but the people that didn't have those genes were weeded out. And those same genes are also involved with the development of inflammatory bowel disease, like Crohn's disease. So inflammatory bowel disease was just the cost of doing business to survive the Black Death. Now we look at Dupuytren, and I don't know what the stress was, but Dupuytren is common enough in the population that I believe there had to be some environmental threat to humans that Dupuytren genes gave some kind of survival advantage to. So if you have Dupuytren, it's not a flaw. It's a badge that your ancestors were survivors and that it gave some benefit that let your ancestors be stronger than their colleagues and to have you ultimately. So why do some people get Dupuytren? Let's say people have the genes. Genes are the biggest risk factor by far. But Dupuytren is described as a two-hit disease, like other genetic diseases. So you have the genetic risk, but then you have some other thing that seems to activate the disease. So just having the risk doesn't mean that you have the disease. The biggest influence is just passage of time. As people get older, they accumulate epigenetic changes that regulate their DNA, what genes are turned on and turned off. This is the nature of aging. Epigenetic changes are responsible for all the changes that we go through from being in the womb to going through childhood, adulthood, and then aging as the years go on. Old age is not just that our bodies are wearing out, it's actually genetically controlled factors. And so those changes probably interact with the Dupuytren genes to be the major risk factor for individuals developing Dupuytren. There are other risk factors that also increase the odds, but they're relatively small in their influence. They're not a major influence on whether someone gets Dupuytren on their own. So injury to the hand, chronic heavy manual labor, and it really has to be chronic and heavy. The needle doesn't seem to shift until people have at least 10 years of daily heavy manual labor. Chronic heavy drinking, chronic heavy smoking, these all move the needle a little bit toward getting Dupuytren, but the big risk factor is genes. Interestingly, it's known that the average person with Dupuytren is a little underweight compared to the average person their age without Dupuytren. And it's been shown by several different overlapping studies that obesity is a protective factor when it comes to Dupuytren. People who are obese are less likely to develop Dupuytren. They're less likely to have surgery for Dupuytren. And there was a study that followed people who had had bariatric surgery, weight loss surgery, that showed that obese people who had successful bariatric surgery, that removed the protection from getting Dupuytren and increased their odds of developing Dupuytren. So interesting factors that we still are not at the bottom of yet. How does Dupuytren progress? Well, we know some things. There are still some things we really don't know. Dupuytren is very unpredictable. Not everyone who has a nodule will progress to developing a cord. Not everyone with a cord will progress to developing a contracture. But on average, if someone with a nodule progresses to a contracture that needs treatment, the average time for that is about 8 years. There's a lot of spread of that, but that's one number that we have. However, what we don't know is when someone develops a contracture, how fast does that contracture progress? We just don't have information on that. Nor do we have information on what precedes the nodule. There's clearly a preclinical aspect of Dupuytren when the biology is activated, but everything looks normal, even under the microscope. And that preclinical phase may be short or it may be decades long. We just don't know. So this is something that needs a lot more understanding. And then when someone has a nodule, what is the likelihood of progressing? So we don't have enough information on this to be more clear than this, but if someone develops a nodule, over the next 10 years, about 1 in 10 nodules will go away on their own without any treatment. That makes it difficult to study preventive treatments because sometimes it just goes away. Over the 10 years that follows the first development of a nodule, about 2 in 10 people will develop a bend in the finger that's bad enough to either be ready for a corrective procedure or will have had a corrective procedure by 10 years out. And the remaining 7 out of 10 people, 10 years after the nodule first appears, either will have no change or they may have a contracture but not one that's bad enough to require any treatment. In terms of treating Dupuytren, surgeons only treat bent fingers. Surgeons clean up problems after they've happened. They don't do preventive treatment. So there are 2 types of procedures that are offered to people with bent fingers. One is Open procedures. This is open surgery. The most common way that Dupuytren is treated is with a fasciectomy, which is a type of open surgery. With open surgery, the way it's done is that the skin is opened up and the obviously diseased tissue is removed. That removes the tether that's keeping the finger bent and allows the fingers to straighten up. A bigger version of that is to remove the diseased tissue and to remove the overlying skin, because the skin is thought to be a reservoir for the Dupuytren biology, and that's usually reserved for people that have more severe Dupuytren biology. Minimally invasive procedures, in these, no tissue is removed. All that's done is that the tethering cord is disrupted, is cut or torn. The most common minimally invasive procedure is a collagenase injection. Collagenase is sold in the United States under the name of Xiaflex. And the way that works is that the doctor gives an injection of this enzyme that weakens the collagen in the cord. That soaks in, and after a day or a few days, the person comes back to the doctor with a weakened cord. The doc numbs up their hand, pulls on the finger, and the cord tears under the skin like a piece of rotten rope. The other version of a minimally invasive procedure is a needle fasciotomy or needle aponeurotomy or needle release. With this procedure, the doctor numbs up the skin right over the cord and uses a small hypodermic needle to go through that area of numb skin to feel where the cord is, and the little edges on the tip of the hypodermic needle the doctor uses like a miniature scalpel to cut through the cord by feel, and then stretch the finger out. Having cut the tether, the finger can straighten out. Now, neither of these is perfect. There are advantages and disadvantages of each. The open procedures have the advantage of lasting longer on average before there's a recurrence, and they are likely a bit better for more severe contractures. Minimally invasive procedures have the advantage of having a faster recovery, days or weeks instead of months with open procedures. And they have a much lower complication rate. A couple % of people that have open surgery will have permanent complications. That's not generally an issue with the minimally invasive procedures. So the things that affect outcomes depends on when you're looking. The immediate outcomes after treatment are largely determined by anatomy. And there are two bits of anatomy that figure in. One is what joint is involved. The PIP joint, the joint in the middle of the finger that you'd knock on a door with, that joint is a troublemaker in all of hand surgery. And in Dupuytren, it's less likely to be straightened all the way with a corrective procedure, and it's more likely to recur after it's been straightened, all compared to the MCP joint. The other thing that affects immediate outcomes is how bent the finger is. The sweet spot for doing a corrective procedure is somewhere between about 20 and 40 degrees, the green area on this clock. So clock is a poor man's protractor. Every hour is 30 degrees. So you don't want to operate or do a corrective procedure before someone has much of a bend, because it's hard to justify any risks. But after 40, 45 degrees, and certainly after 60 degrees, there is a greater likelihood of having other changes in the fingers and other changes in the hand that will prevent a good result. So the angles also affect the rate of progression before surgery and after surgery. And this is a simple geometric explanation, although this slide looks pretty complicated. The two triangles up on the top have yellow circles in them, and the yellow represents how much change in the length of the cord there is. And you can see the closer the cord is to the pivot point of the joint, the axis of rotation, the more of an angle change you'll get. And so cords that are closer to the joint have more of an effect and tend to progress more rapidly. Cords in general are closer to the pivot point of the PIP joints than they are of the MCP joints. And this is one explanation of why the PIP joints are a problem with Dupuytren. So that's one effect, the anatomy, which tends to affect the immediate outcomes after treatment. That is, whether or not the finger will be able to be straightened much or all the way. The effect of biology is mostly on whether the finger will stay straight after it's been corrected. And part of the problem is that Dupuytren biology has some overlap with the biology of wound healing, and any kind of procedure is traumatic. Open procedure is more traumatic than minimally invasive, and the trauma of a corrective procedure may actually trigger the biology more, and so the finger may not stay straight. And to make it even more complicated, if the anatomy is bad, if people have developed secondary changes in their tendons and ligaments from severe contractures, then the finger won't be able to move normally afterward, because the tendons will be stretched out, and it tends to make corrected fingers spring back. That tends to be an earlier process. But I mention this because not all recontracture after a corrective procedure is recurrence of Dupuytren disease. We can look at these two hands. The hand on the left, this person had fasciectomy 2 years earlier. You can see I've marked her fasciectomy incisions with a marking pen, and she was initially straight, and now she's really not straight. On feeling her hand, there's no Dupuytren that can be felt. And so this recurrent contracture is mechanical. It's not due to the biology of Dupuytren. It's due to the mechanics of the fingers and tendons being damaged by severe contractures. The hand on the right marked this person's fasciectomy incisions with a marking pen, and you can see clearly there's a cord. So this is typically a picture for recurrent Dupuytren biology, but it's not always clear, and usually you can't tell whether it's a mechanical recontracture or a biologic recontracture other than in retrospect, in hindsight. So if someone has a corrective procedure, it's not uncommon for people to be straight and then lose a little bit of their correction in the first few months after a corrective procedure. If they do that and then they stabilize, then the loss of their initial correction was just mechanical. That's an anatomic recontracture. If someone loses a little bit of contracture and then they continue to lose some of their correction over the months that follow the first 3 months, then that is persistence of Dupuytren biology. That is, there's something keeping the disease active. And for example, Dupuytren biology is provoked by tension on the tissues. So if a cord wasn't fully released, then it can keep pulling on the area, and that can provoke persistently active Dupuytren biology. That's not a recurrence, that's persistence. If someone has a corrective procedure and at a year they seem stable and they stay stable for a while after that, and then they start contracting again, that's true biologic recurrence. The disease was quiet for a while and then it reactivated. So knowing all these, knowing about the biology, knowing of the anatomy, we could plot out an ideal management of Dupuytren disease based on how severe the biology is and how severe the bend is. So if someone has a mild contracture and has a mild biology, then treat them with a minimally invasive procedure. If someone has a severe contracture but mild biology, then you go up another rung on the ladder, do a fasciectomy, and if they have a really bad bend, particularly in the PIP joint, you can do a thing called skeletal traction, which slowly stretches the joint out prior to fasciectomy. If someone has a mild bend but has severe biology, then you could make the case to do a dermofasciectomy, to remove the Dupuytren tissue and remove the skin over it and resurface it with a skin graft, because that prolongs the period of time before there's a recontracture. And if people have severe biology and a severe contracture, you throw everything at them. You do skeletal traction to straighten out the joints and then do a dermofasciectomy. And that really looks pretty tidy. The problem is we don't have great measures for either the anatomy or the biology. So we use, for the biology, a thing called diathesis. And diathesis was developed on observations of factors that might increase the likelihood of early recontracture after surgery. And the people that started working on this believed that having a strong family history of Dupuytren, like these cousins on the left, having an early age of onset, typically younger than 50, having Dupuytren nodules outside of the palm, like letter hose or knuckle pads, and some other factors. But these are the main factors that were thought to be associated with an earlier recurrence after surgery. And those factors are called diathesis factors. Now, taking this, the idea was extended, thinking, well, it's logical that if someone has these factors and it increases their risk of having an early recurrence after surgery, then they progress more rapidly after surgery, then logically they might progress more rapidly before surgery. That's a common thought. There's no evidence to back that up. And in studies looking at this and work that I've done, the progression prior to a corrective procedure doesn't seem to be influenced by family history or age of onset or disease outside the palms. And this is important because when people are first diagnosed with Dupuytren, they might say, oh gosh, my dad had Dupuytren and I got this when I was 45, so I'm going to be crippled within years. And there's no data to back that up. It seems as though the break point seems to be when someone has a corrective procedure. So that's a questionable issue of the biology, because we don't have an objective test of biology, and these demographic factors are helpful, but they're kind of squishy. You can't really put a number on recurrence based on these factors. The anatomy is similarly hard to quantify. And you might think, well, quantify, we use a protractor and that's got numbers on it. Numbers are quantitative, and so this must be a really quantitative measure. But it's not, and here's one reason why. Oftentimes when someone comes in to see a physician for their Dupuytren, they're told, put your hand flat on a table and you don't need to have any treatment until you can't get your palm flat down on a table. And that's called the tabletop test. And typically, if someone doesn't get an abnormal tabletop test until they have a fair bit of contracture in the MCP joint, as in the top right, or the PIP joint, as in the middle right. But there's a problem with this, because if someone can hyperextend their MCP joint, that can mask a bent PIP joint. And so someone who's told to have a come back when they can't get their palm flat down on a table may miss the window of opportunity to get the best result between 20 and 40 degrees on that PIP joint. So that's a problem. There's a bigger problem, though, which is a joint that we haven't talked about before, and that's the carpometacarpal joint. Now, in this animation, you can see that this demonstrates cords that span several joints. And in this animation, the finger is able to straighten one joint, the PIP joint, or the MCP joint, just not both at the same time. And so the question is, what are the angles there? You can't really put a number on it, because neither joint actually has a fixed contracture, because the cords span multiple joints. The other thing is that there's another joint in the base of the hand, particularly for the ring and small finger, that has motion that we can't measure. So this is the carpometacarpal joint, or CMC joint, and that's responsible for this kind of motion in the hand. That's what moves when you cup your palm. That's what moves when you go to make a fist and grab something hard, it drops down, and that gives you a three-point pinch, this side, and the underside, which gives you a much more secure grip. So it's got a fair bit of motion, about 40 degrees of motion on the pinky finger CMC joint. And we can't measure that joint, but it gets involved with cords that span multiple joints. So the patient on the right, I'm pushing her finger straight, and if I could put a ruler on the back of her finger and say, gosh, there's no contracture there. But I know that her carpometacarpal joint is flexed forward. If I push on the bone just past that joint and straighten out her CMC joint, then here I'm pushing on her finger pretty hard. You can see the fingertips blanched, and she has about a 40-degree bend in that MCP joint. So the question is, what is her bend? Are we measuring this? Can we measure it? No, we can't really do that. And so these are significant issues with the measurement of Dupuytren contracture. And the other issue is that the goniometer, the protractor, doesn't reflect a lot of other issues that are involved with Dupuytren. So when you ask people what bothers them about their Dupuytren, it's often hard to explain. People will describe certain activities they have trouble with, but a lot of people just say, well, it just interferes with everything I do. And that's not reflected with angle measurements. About a quarter of people will have pain or itching or tenderness in their Dupuytren affected areas. That's not something you measure with a protractor. A number of people will have, it's fairly common to have issues with dexterity, doing fine manipulation, and that's because the mechanical changes in the hand, even with early Dupuytren, can upset your control over your fingers. And people notice this difficulty doing tasks that they used to be able to do automatically. That's not measured by an angle. And then going back to this carpometacarpal joint, and a little anatomy lesson of the hand. You've probably been told that humans are unique because they're the only primate that has an opposable thumb. That's not true. There are other primates that have an opposable thumb. What opposition is when you take a digit and flex it and rotate it so that it can face one of the other digits. That's opposition. So here I'm opposing my thumb to my index finger, but if you look, you can see my index finger the pad isn't touching my thumb. And the two things that humans have that are unique to humans that other primates don't have are other digits that can oppose. So there is a index finger opposition. So the index finger, when it flexes, it can rotate to meet the thumb and have pulp to pulp contact, and that's unique to people. And then the carpometacarpal joint, the CMC joint, allows the pinky finger to flex and rotate over toward the thumb as well. And this is an example of the fact that our fingers, you'd think that the fingers work like hinges, because when you bend them down, they all come side to side. But in fact, if you bend them one at a time, they all tend to go to the same point on the palm. And in the pinky finger, that motion is also associated with rotation of the pinky finger toward the thumb. So you can have pinky to thumb, pulp to pulp contact. We did a study on dexterity and keyboard issues that people report commonly with Dupuytren. And specifically, people report using a keyboard that they hit the wrong keys, sometimes before they really have much of a measurable contraction. We plotted out the keys that people wanted to hit and the keys that they hit that they didn't want to hit. The yellow on this diagram in the bottom right are the ring finger for touch typers, and the green are the pinky finger for touch typers. And plotting out the directions, they tend to go down together, which goes along with the carpometacarpal involvement with Dupuytren contracture. And I mention this because this is just yet another thing that just measuring finger angles does a terrible job for. So we have issues with the biologic measurement, we have issues with the anatomic measurement, and so that means that tidy little 4-component box of how to treat Dupuytren is pretty hard to follow. So what people actually do in practice is a bit of trial and error. And this is a common kind of triage and decision tree for people with Dupuytren that's used. You start with a minimally invasive procedure. Regardless of what you think the biology is, regardless of the anatomy, it's a low-risk thing, and if somebody has a minimally invasive procedure and it lasts at least a year and it works well, then if it comes back, you can repeat it. It's a low-risk thing. If it doesn't work well, or if it doesn't last at least a year, then you go the next rung up the ladder and have an open procedure, like a fasciectomy. If an open procedure works well and lasts at least a year, if it comes back, you can have a repeat open procedure. But the complication rate of doing repeat open procedures is significant, and so you really have to have a good reason to do that. If you have an open procedure and it doesn't work well, or it doesn't last at least a year, then you do something else. And that something else usually is reserved for people that have recurrent PIP contractures, because they are the devil in Dupuytren. One option, these are the options you can think about. One option is just accepting it the way it is and say, I'm not going to do anything else. This is the way my finger's going to be. And oftentimes for PIP joints, it'll get to a point and it will stop contracting. That is, the joint itself, the ligaments around the joint will take the stress off of the Dupuytren tissue, and it won't progress beyond that. And this is something we don't have a good way to predict. I've got redo up there and scratched out because of the risk involved and the benefit. It doesn't make a lot of sense to redo a procedure that didn't work well. I'd call that going down swinging. And so if something's going to be done, it makes sense to do something which has a greater likelihood of working well and lasting a long time. So these pictures on the right are a patient with a digit widget. Now, a digit widget is an external fixation technique. This particular device is attached to the middle bone in the finger, and then that attached area is connected to a hand splint with rubber bands that slowly pull on that joint. And so that's on for 6 to 10 weeks and slowly straightens out the finger. It stretches out and grows the tight tissue longer. It's not the permanent fix, because if you just stretch it out and you take the thing off, about half the time the contractures come back pretty quickly. So the usual way this is done is to stretch the finger out and then go in and do an open procedure to clean things out and possibly a dermofasciectomy. So that's got a better outcome than just trying again, by good measure. If that's not a choice, then the next rung on the ladder is salvage. The goal of salvage procedures is not a normal finger. It's a finger that's less of a nuisance than the finger that you currently have. The most common salvage procedure is a joint fusion. And in this joint, if the joint is stiff and bent in an awkward position, the argument is, well, let's have it stiff and bent in a less awkward position so it doesn't catch on anything. So the advantage of doing a PIP fusion is that the Dupuytren won't make that finger bend at that joint anymore. You still have the end joint will move. The disadvantage of a PIP fusion is that that joint doesn't bend anymore. So when you make a fist, it doesn't tuck in all the way, which you can bend the end joint, but that can be a significant functional impact with racket sports, golf, tennis, and things like that. So it's not a perfect solution. And then if people have had a number of operations and complications in the operation, they've got a bad finger and they're just sick and tired of that bad finger, they may think, well, maybe it'd be better to not have this finger. My hand would work better if this finger weren't in the way all the time. And that's when you start talking about amputation. Not a common choice at all, sort of the last procedure of last choice. But failed Dupuytren surgery is the most common reason for people to have an elective finger amputation. That is, scheduling to have their finger removed because that would be better than what they currently have. That fact alone is, I think, the strongest case that somebody could make that we need to have better treatments for Dupuytren, because we're talking about amputating somebody's finger for a condition that's benign and usually painless. That just means that we are failing in doing justice to people with this condition. Amputation and all of these something else procedures only exist because of the problem of recurrence. Recurrence, recontracture, is the elephant in the room. Recurrence is influenced by the type of procedure you do. So people that have minimally invasive procedure, about 10 to 20% will have a recontracture by a year out. And again for the next year and again for the next year. With fasciectomy, those numbers are 5 to 10%, and with dermofasciectomy, about 2% per year recontracture, generally with a quiet time for a number of years before recontracture is an issue. Other factors influence recontracture. As we talked about, the MCP joint is less prone to recontracture than the PIP. People that have more of a severe bend are more likely to have a recontracture than less. And people that have their fingers straightened out all the way with a corrective procedure are less likely to have a recontracture than people who only have a partial correction. So is there any way that we can move the needle on this? What makes Dupuytren better or worse? Well, we know that the big risk factor of how severe the Dupuytren is, whether it'll keep progressing, is related to the genetic risk that someone has. We talked about the other risk factors that are involved with triggering Dupuytren, but there's no good evidence that any of these other factors, injury, heavy manual labor, maybe smoking, drinking, diabetes, that those really change the rate of progression. So that's puts us in a tough place, and people want to do something. So in terms of simple things that can be done, one option, because we know that mechanical forces are involved with Dupuytren, is to be nice to your hands and to shield them from mechanical stress. Wearing padded gloves, doing heavy activities is a reasonable thing to do. If you're working out, you can get pull-up handles instead of having all that force on the Dupuytren prone areas, doing pull-ups, in doing push-ups or a downward dog yoga position that stretches the tissues, which may also be a provoking thing, and you can use push-up handles for those, or even hold small dumbbells and not stretch your hand back. The other thing is that the narrower a grip of something that you're holding, the more mechanical stress it puts on the tissues. So having a larger grip on your tennis rackets, other racket sports, golf clubs, that reduces the amount of mechanical stress. And that's something that's easy to do, low risk, and can't hurt, might help. But it doesn't make Dupuytren any less frustrating. Dupuytren's frustrating to patients and also very frustrating to surgeons. It's frustrating because it's persistent. In some people, the Dupuytren just tends to keep going and going and going. It's frustrating because it's unpredictable. You can have two people that look the same and have wildly different outcomes with either no surgery or after surgery. But maybe it's not that Dupuytren is unpredictable. Maybe it's just that we don't have the right tools to be able to understand the biology and predict what's going to happen. And maybe it's not that it's persistent as much as we don't have medical treatments to turn off the biology, to slow that biology down. We need some kind of disease-modifying treatment or disease-modifying drug, as we do with other medical conditions. You get a test, you find out where you stand, you get put on some kind of medical treatment, and that seems like a reasonable way to treat Dupuytren, but we don't have the wherewithal to do that right now because we don't have a test of Dupuytren biology. So as an example, here are two hands. This hand on the left has soft skin. It's got a very well-defined cord. Everything seems great except for having that cord under the skin. The hand on the right has hard skin. The skin is stuck down to the cords that are underneath the skin. And she's trying to straighten her fingers out, and she's doing it strongly enough that the skin over the cords is blanching. That yellow is just, the skin is really tight. So the question is, what's the difference between these two hands? What's the difference between these two people? Is this even the same disease? What's going on biologically with this? These hands, the patient, excuse me, the patient on the left has nodules all over the palm and has some dimples by the thumb, which is another geographic change that people can get with Dupuytren, but no contracture. It's been that way for years. The person on the right has soft skin and swears that he never had a nodule anywhere. So what's the difference between these two hands? What's the difference between these two biologies? The hand on the left has soft skin, thin, really thread-like cords. You could see them. You could almost just grab them between your fingers. The hand on the other side has hard skin. There's no plane between the skin and the underlying cord. And if you operate on this, you wouldn't be able to find any boundary between the undersurface of the skin and the cord. And the skin's obviously involved in that area. What are the differences biologically between these two people? We lack a simple test to be able to understand these obvious biologic differences between these two between these two types of Dupuytren disease. And the reason that we don't have a biomarker test has to do with the differences between surgical and medical research. So this is a kind of an analogy. There's a problem. There's water on the floor. Surgeons get called in for damage control to clean up the mess after it's happened. Medical doctors' goal is to prevent complications from happening by turning off the biology at its source. And this plays out on the design of research to develop preventive medical treatments. So medical doctors use biomarkers because they can tell what's going on before there are complications, before there are clinical changes. So if you have biomarkers and you wanted to develop a treatment to stop the progression of Dupuytren, what you'd do is you'd measure the biomarker, which acts as a proxy for disease progression. You'd give some kind of treatment, and you'd wait weeks for the treatment to affect the biomarkers, and then you retest the biomarkers because that is a way to tell ahead of time whether you're at risk for having disease progression. But we don't have biomarkers. So if we wanted to test whether a drug could prevent people going from a nodule to a contracture, this is how we'd have to do it. We just use angles as our endpoint for our outcome measurement. Knowing what we know about Dupuytren biology and the fact that sometimes nodules go away on their own, statistically, to get good results, you'd have to enroll 1,000 people. Half of them you would treat with your treatment, half of them you would treat with placebo, and then you treat or wait at least 5 years, then measure everybody's angles and try to determine from that whether or not the treatment impacted the number of people that went from nodule to contracture. That's a big, logistically challenging study, very difficult to do. So you might think, well, that's pretty inefficient and takes a long time and a lot of people. Wouldn't it be more efficient to see if we could affect the recontracture rate after a corrective procedure? Because people tend to progress more rapidly after they've had a procedure than before they've had any kind of treatment. And so we could do that. There are some caveats on that. One is that we'd focus just on PIP joints, because PIP joints tend to recur more predictably and more rapidly than MCP joints after a corrective procedure. We would have to look at PIP joints that were isolated, that didn't have cords spanning multiple joints, but just a cord in the finger so that regardless of the MCP motion, the PIP joint wouldn't be affected. We would look at people that had a minimally invasive procedure, because recontracture rate is faster after a minimally invasive procedure than after an open surgery. We'd use XIAFLEX because that would remove the operator bias, because it doesn't matter if you're a technically excellent surgeon or not quite as excellent, it's the XIAFLEX that does the work. And we'd also look at people that had success, that is complete correction of their contracture at the end of surgery. But it's a bit more complicated than that, because to get 220 people with isolated PIP contractures that had success after XIAFLEX, we'd actually have to treat 286 people because we know that about 70% of people that are treated with XIAFLEX for PIP contractures will have a straight finger and 30% will have an incomplete correction. And then to get those 286 people, we know that only about 1 in 5 people with Dupuytren contracture have an isolated PIP contracture in their hand. So we'd have to start with over 1,400 people to cull down to the 286 to get the 220, and that winds up being a big, expensive study. So the question is, we have a lot of different medicines that might modify Dupuytren biology. We have a bunch of different treatments that, in theory, might turn Dupuytren biology off. So knowing what we know about how research is done, which of these has been shown to prevent progression and prevent recurrence? And the answer is none, because it's hard to do research without biomarkers. You have to do studies that are really unaffordable at this point. So the lack of a biomarker test is the single biggest factor that we're not developing better treatments for Dupuytren. And this has a lot of implications, even just looking at treating nodules. The question is, why treat nodules? Well, there are two different situations that people find themselves. One is that a minority of people will have symptoms in their hand, pain, tenderness, itching, difficulty using their hand because of those. And we do have some treatments that will affect those symptoms because those are due to inflammation. And you can make those feel better with anti-inflammatory treatment with cortisone shots. Radiotherapy actually is fairly effective in reducing these inflammatory symptoms. And so that's a kind of a predictable result. But a lot of people with nodules aren't seeking treatment because of that. They seek treatment because they're anxious about the possibility of progression. And the problem is we don't have a treatment that has a known benefit in preventing progression of people that just have nodules. And this impacts the decision about what kinds of treatments to look at. So if someone has pain, tenderness, itching, and you know that the treatment has a reasonable chance of affecting those, you can calculate the risk-benefit ratio. So you know that the benefit is those symptoms will go away, and we know what the risks are of some of these treatments. All the treatments here have a potential significant risk, but it's the person's decision to be able to compare risk and benefit of whether they're going to go with that with treatment. However, if the issue is there's a nodule and there's anxiety about progression, and we just don't know what the benefit long-term of treatments are, it's really hard to justify taking on any risk when you don't know what the benefit is. So one approach is to hold off on doing riskier treatments for people that are anxious about progression and go with treatments that are less risky, topical treatments, nutritional supplements. It's dealer's choice. The patient can make this call, but that's one way to reframe the conversation. Are you getting, is your risk-benefit ratio justifiable? We don't have a biomarker test because of some logistics. So one issue is that typically biomarkers are developed based on tissue findings, but a biopsy of a Dupuytren nodule is a risky thing. It can set off the biology and aggravate or provoke progression. So biopsy just as an isolated measurement is not a good idea. It's not justifiable because of the risk. For other types of research, you grow the tissue in a petri dish in the lab and then can look at how it responds to different kinds of treatments. The problem with Dupuytren and other fibrotic diseases is that once you take them out of the body and grow them in a dish, it changes the biology. So you have the Dupuytren biology, but you also have all this artifact biology. So you don't know if what you're measuring and how it's responding in the lab is treating Bruce Banner or the Hulk. And this is a problem that we don't have a good answer for. So looking at all this, the remaining area to look at is the blood. Now you might think, well, this Dupuytren's in the hand. Why would we suspect that there's something going on in the blood that we could do something with that information? And the answer is that anything that happens in the body that begins as a biologic problem, not as a mechanical problem, the whole body is involved with. So if you got a cut in your palm, and as that healed, you might think, well, that's just local healing in the palm. But really what happens is when you have a cut in your palm, damage to the tissues, those damaged cells release special molecules into the bloodstream. They circulate through the whole bloodstream. When they pass through the blood in the bone marrow, that triggers the bone marrow to deploy special repair cells that are sitting in the bone marrow into the circulation. They circulate around through the body, and they find the area where the signal's coming from and move out of the bloodstream into the tissues and start the repair process. So any healing process that's going on in your body involves your entire body. And the same is true for Dupuytren. There are some studies that have found some different findings in Dupuytren, in the blood of people with Dupuytren compared to people that don't have Dupuytren, and that's what needs to be explored further. So that's the first step in developing a medical treatment for Dupuytren, is finding the molecular markers or biomarkers in the blood. And then once we have that, we can develop a blood profile to diagnose Dupuytren. Is this lump Dupuytren, or is this just a lump that looks like Dupuytren? Staging. Do I have the bad version of Dupuytren, or do I have the kind that I really don't need to worry about? Biologic response. Is this medicine changing the biology or not? And once we have that information, once we have information about biomarkers in the blood, we can look at drugs that might modify the biology. And ideally, repurposed drugs. A lot of drugs have many different effects. Aspirin can fix your headache, but it's also a pretty good blood thinner. Thalidomide was a sleeping pill that was pulled because it caused birth defects, but it shows great promise in treating leprosy and some other diseases. Who'd have thunk it? Once we have drugs that look like they're good candidates, we can see their impact with clinical trials and develop a standard medical management for this condition. And this is one of the major goals of the International Dupuytren Data Bank. If you haven't enrolled in this yet, whether or not you have Dupuytren, we need people with Dupuytren, and we need people who don't have Dupuytren to act as controls. Go to dupestudy.com and enroll. This is a free online crowdsourced patient registry. We've recruited people from this for our first blood biomarker discovery pilot study, which is currently underway. We launched this study just coincident with the launch of COVID. So we've had to make some course adjustments, but it's going along very well. We currently have 45 participants, 25 with Dupuytren, 20 controls, and we're running a whole host of gene-related tests and protein-related tests looking at the blood to see differences between people who have Dupuytren and people who don't have Dupuytren. But it's more than just identifying what biomarkers are out there, because the biology is staggeringly complicated. So these yellow areas are some of the proteins that are involved possibly with Dupuytren biology, and all the other circles are other proteins that interact with these proteins. And I made this diagram by limiting the number of interactions. If you opened it up and had as many interactions as have been documented, it'd be like looking at the sky on a cloudless night. So there's a lot of work that needs to be done in analyzing this complex data, and it's just a matter of time and persistence. Persistence, teamwork, insight, and luck. And we will get to where Dupuytren needs to be. To find out more about this, see the website, dupuytrens.org. If you haven't enrolled in the International Dupuytren Data Bank, now's the time to do it. And if you're in a position to be able to support Dupuytren research, we are funded entirely by charitable donations at this point. The National Institutes of Health doesn't support discovery research. It only supports research that has some pilot preliminary data to validate. And so right now we're still entirely dependent on your generosity. And thank you very much. Have a good day.